Hi, I'm Beverly Brock, and I'm getting ready to discuss Chapter 33, Drugs Affecting Hematopoiesis. And I'm going to show you my PowerPoint slides as I present here. You will see the slides. You'll get to see my screen. Okay, Drugs Affecting Hematopoiesis by Beverly R Brock, and I'm in the cohort here at ECPI online, and this is Pharmacology 602. And my first slide are the learning objectives for this chapter. At completion of this chapter, the student will identify core knowledge about drugs that affect hematopoiesis, identify core patient variables relevant to drugs that affect hematopoiesis, relate the interaction of core drug knowledge to core patient variables for drugs that affect hematopoiesis, generate a nursing plan of care from the interactions between core drug knowledge and core patient variables for drugs that affect hematopoiesis. They'll also be able to describe nursing interventions to maximize therapeutic and minimize adverse effects for the drugs that affect hematopoiesis. And they'll also be able to determine key points for patient and family education for the drugs that affect hematopoiesis. The introduction. Hematopoiesis has biologic modulators or biologic modifiers, and they're a group of biologic pharmaceuticals that are naturally occurring proteins used to alter the body's hematologic or immunologic responses. And these substances are called biologic therapies. And similar drugs from this class may also be used to suppress the immune system to prevent rejection from foreign transplanted tissue or to prevent rejection of the body's own tissue as an autoimmune response. And with this, what they're talking about with the therapies here, some of these drugs are used for people who have bone marrow transplants. They're used in patients who have renal failure to stimulate regrowth of red blood cells. And define hematopoiesis. Hematopoiesis is the production and differentiation of blood cells normally occurs when within the bone marrow. Hematopoietic growth factors are substances generated by the body to enhance production of the blood cells. Prototype for blood cell production, white blood cell production, and platelets. Epoetin alpha, also called epigen and procreate, are a hematopoietic hormone and is the prototype drug for stimulating red blood cell production. The prototype drug for white blood cell production is the colony stimulating factor, filgrastim, and it's called Neupogen. The prototype drug for creating platelets is oprevlican, also known as interleukin-1, and the brand name for that one is Numega. Here's what you can find in the book where it says drugs affecting, and it's kind of a chart, and I wanted to include it so you would understand what it meant if you saw it there in the book. And the symbol with the C indicates the drug class, so it shows the erythropoiesis stimulants, the colony stimulating factors, and the interleukins. And then on the bold type with the P, they're showing the prototypes, which is epoetin alpha, the filgrastim, and the oprelvicin, which is the interleukin 11. Excuse me for being tie-tongued. But I did that there just so you could see, you know, what that means when you see it in the book. It's just giving you the different classes and the prototypes for the drugs and just telling you exactly what the drugs are doing. Now, table 33.1 is kind of like a table that's trying to kind of get you to understand the drug therapy and that affects the blood cells. Now, you'll see the different classes here, how I have it, the cell type, and I'm showing what the drug to increase production, the impact of drug therapy, and the indications. Now, take a look at the red blood cells. They are epoetin alpha, and what they do, elevate or maintain the RBC levels and improves oxygenation to the tissues. And some indicators where this drug may be needed: people with anemia, an HIV patient, a kidney patient, a cancer patient, or a patient receiving anti-cancer drugs. So that would mean a patient that is on chemotherapy. And for WBC, which is the white blood cell, the filgrastim, increase neutrophil count to fight infection and decrease the risk for infection. And some indicators here in patients who would have it would be a cancer patient, a patient in need of a stem cell harvest, or receiving chemo drugs as well. Now, the other one, the cell type here, is platelets, and the drug used to increase production is oprevlican. This one, and it's used to increase platelet production, prevent bleeding, and allows for clot formation. And some indicators for this drug would be a cancer patient receiving anti-cancer drugs, which would be, as we all know, a chemo drug. Now, the physiology of the words in this chapter, and give you a little bit of background on that. The immune system is composed of the hematopoietic cells and multiple immunologic production and storage sites. Now here you're going to show where these cells here are going to show how the red blood cells are reproduced, and also how, whenever you have an immune response, the cells that are responsible when this begins to happen. And also going to give a little bit of background about stem cells and what the stem cells are. Now, the hematopoietic tissue is found in the bone marrow. It's also found in lymph nodes and in the lymphatic channels of the body. Now, stem cells are located in the bone marrow. They're found in long bones, such as the vertebral skeleton, and these stem cells produce three types of functional hematopoietic cells. Erythrocytes, they're also called red blood cells or RBCs. Leukocytes, also called white blood cells or WBCs, and platelets, which are small cells necessary for blood coagulation. And then you have the reticuloendothelial system. It includes the immunologically active tissue and cells found in the lymph system. They're found in the spleen, the liver, the lungs, the gastrointestinal or GI tract, and the brain. And an integrated immune response involving hematopoietic cells and immune tissues provide the body's nonspecific and specific responses. And this is to envision by antigens identified as non-self. And what this means is, when you have this response, there could be something going on in the body that may not be specifically indicated, and these cells are going to respond if there's an antigen present. The essential component of the immune system are the hematopoietic cells and their barrier defenses. And like I said, we have the non-specific immune response and the specific immune response and the immunity itself. And I wanted to touch a little bit on the immune system there, with what it's talking about with the specific immunity. When the invader gets past the barrier and the non-specific immune system, and it enters into the bloodstream, you get a specific immune response and it involves the leukocytes, and they're initiated. And the bone marrow stem cells, they're kind of develop into two types of lymphocytes. You got your T lymphocytes or T cells, and your B lymphocytes or B cells. And what these two T and B lymphocytes, they're going to be, they differentiate into specialized cells, and they're called like natural killer cells. And what happens, the lymphokinase kind of activated killer cells is what they're called. And these cells aggressively detect and destroy neoplastic cells. And what it does, whenever something's happening, there's cells that it shouldn't be there, these cells are activated, and they go into like killer mode, and the immune response happens, and we're all familiar with that, and it causes the cells to die. Now, sorry about that. Now we have the talking a little bit about the individual cells. We have the hematopoietic cells, which are the red blood cells, and they mainly compose of hemoglobin, which enables the cells to carry oxygen to the cells in the body. And a little brief description of these: they're biconcave shaped cells, and this makes them flexible so they can maneuver their way through small capillaries to deliver oxygen to the tissues. And the major hormone peptide or glycoprotein that stimulates the production of these, which is called erythropoiesis, is called erythropoietin. And this particular hormone is produced by the kidneys in response to, if a patient should have some issue with hypoxia or reduced oxygen carrying capacity of the blood. That's when these cells would be stimulated. Now, hematopoietic cells continued here. When the hemoglobin levels fall below 12, as in anemia, the erythropoietin production is stimulated to maintain the body's homeostasis. And when the erythropoietin in turn stimulates the progenitor stem cells to make the RBCs, and these cells live about 120 days. Now, the plasma erythropoietin levels vary from 0.1 units per milliliter to 0.03 units per milliliter, and they increase 100 to 1,000 fold during hypoxia or anemia. And when the hemoglobin levels are elevated, the erythropoietin production is halted, and it ends the stimulation to produce the red blood cells. Now, here's some components of the cells that we're talking about. Now, iron is a primary ion revisibly bound to oxygen in the heme molecule, and it's necessary to support erythropoiesis. Platelets are also formed, are the formed element involved in the blood coagulation. And platelets are small cells that arise from the bone marrow precursor cells, megakaryocytes. You have platelet production, and they're also, although stimulated by the many cytokines, is mostly dependent on the action of the interleukin 6 and the peptide called thrombopoietin. And thrombopoietin is produced in the liver, and you get when you get a low platelet count, the stimulation of this hormone causes the production of the poietin, so it can aid in clotting. Now, leukocytes, they're white blood cells, or we call them WBCs, are key components of the immune system's responses. And white blood cells differentiate into three main cell types. You got granulocytes, monocytes, and lymphocytes that all respond to cell injury or foreign invaders. So if you get a cut or you have something that's in the body that has no business being there, an infection or anything that's going on, you're going to get these response from these three cells. Now, the granulocytes are the most common type of WBC, and production of granulocytes is regulated by the colony stimulating factors, and that's CSF, also known as growth factors. And granulocytes are further divided into neutrophils, eosinophils, and basophils. And the formation of the granulocytes, myelopoiesis, is stimulated by many cytokines. These cells are produced in response to, as I said earlier, something going on in the body, infection, inflammation, and even tissue necrosis. Now, here's a little physiology. This little is in the book as well, and I found this to be very interesting. And basically what it's doing is just giving you a little physiology, telling you what happens whenever the thrombopoietin, erythropoietin, and the progenitor stem cells are produced. The kidney releases the erythropoietin, which stimulates the progenitor cells in the bone marrow to produce the red blood cells, or the erythrocytes. And the liver produces the thrombopoietin, which along with the interleukin-6 stimulates the production of platelets in the bone marrow. Then you have your colony stimulating factors. They work on developing white blood cells, the leukocytes, allowing them to differentiate into, as we discussed earlier, 3 cells: the granulocytes, the monocytes, and the lymphocytes. And then the granulocytes, we also discussed, further specialized as either the neutrophils, the eosinophils, or the basophils. Now, non-specific immune responses, you got the neutrophils. They're most common, like we said, granulocyte, and they're considered to be the first line of defense against pathogens that gain entry into the body. And the neutrophils contain enzymes that kill bacteria in the bloodstream. And when the bacteria are ingested, they're killed whenever they're ingested by the neutrophil. And the process of engulfing and destroying bacteria is called endocytosis or phagocytosis. When the neutrophil level or count is low, the patient is considered to be neutropenic or have neutropenia. And when the patient gets to this stage, an infection is likely to occur. And another non-specific immune response, basophils, they're granulocytes, excuse me, that are not capable of phagocytosis but contain chemical substances important for initiating and maintaining the immune response. And some of these substances are histamines, heparin, and chemicals used in the inflammatory response. And we have the monocytes, and they differentiate into immunologically active cells called macrophages, and I think we've all heard of that. The macrophages can be circulating phagocytes or can be fixed in specific tissues. Now we have the specific immune responses, and that's the bone marrow stem cells, and they develop into 2 types of cells: the T lymphocytes or T cells, and the B lymphocytes or B cells. And as we talked about earlier, they're natural killer cells, and the they're lymphokine activated killer cells. And as I said to you earlier, they are identified and they aggressively attack and destroy the neoplasmic cells. Now, when a patient goes into hematologic failure, and this is an inadequate cell production to meet the body's demands for oxygen transport, blood coagulation, or to prevent infection. The deficient cell production is named by the cell involved, and when the production of the cell is deficient, we term it aplastic. And anemia is a condition of reduced circulating RBCs or red blood cells, and can be caused by deficient cell production. And it says here in parentheses, arising from folic acid deficiency, iron deficiency, as we just specified, insufficient production of erythropoietin or bone marrow failure. And you can have abnormal hemolysis, And this can be featured in anemia or hemolytic anemia, and through the loss of blood in large volumes or cells, such as overt bleeding. Now, these all these factors can cause a patient to become anemic, and these synthetic hormones are used to replace the blood cells that are lost due to these conditions. Now, here's a little bit more pathophysiology. A low platelet count is determined to be thrombocytopenia. And thrombocytopenia can result from decreased production, shortened survival, or loss of the platelet cells. And the decreased production, as we said, can come from aplastic anemia. And this can be drug-induced, can be marrow infiltration, deficiencies of vitamin B12, folate, radiation, or even heredity factors. And we spoke of those earlier. Here's another little chart, and it may seem like it's got a lot going on here, but it's basically showing you the drug name, selected indications, routes and dosages, and pharmacokinetics. Shows you how the drug can be administered, and most of these are usually given, they can be given IV, but most of the drugs that I've given along these lines when I've had to deal with the EPO, the Epigen, and the Procrit, they were given sub-Q, and also I've given the filgrastim and or we call it the GCSF, the Neupogen. It was given sub-Q as well. Now, some of these were given the colony stimulating factors, the GCSF, the Neupogen, that was given when I did give that one because people were getting chemo, and most of these drugs that I did give was due to patients who were having chemo. Sorry about that. Now, erythropoiesis stimulants. Now, the prototype drug used to create the RBCs, as we said earlier, is the Epitin alpha, which is the Epigen and the Procrit. And what it is a 165 amino acid glycoprotein, and it's manufactured by a recombinant DNA technology, and it is a recombinant human erythropoietin. Now, the product contains the same amino acid sequence as the natural erythropoietin. Now, the human erythropoietin gene is introduced into mammalian cells, which then produce the erythropoietin that has the same biologic effects as the endogenous erythropoietin. Now, nursing management of the patient receiving the epoetin alpha, core drug knowledge in the pharmacokinetics, the pharmacotherapeutics. The epoetin alpha, also referred to as erythropoietin or EPO, is used to treat anemia associated with chronic kidney disease, and it's used to elevate or maintain the red blood cell level. And these are assessed through hemoglobin determinations and to decrease the need for a transfusion. Now, the pharmacokinetics, epoetin alpha can be administered either intravenously or subcutaneously. When epoetin alpha is given intravenously, its circulating half-life is 4 to 13 hours. And for chronic renal patients, it lasts approximately 20% longer than in healthy adults. And the therapeutic levels are maintained for 24 hours or longer. And after subcutaneous administration, peak levels are achieved within 5 to 24 hours and decline slowly afterward. and mostly the elimination is through the kidneys, and the half-life is not affected by dialysis. So you notice if a person would have some issues going on with their kidneys, that may be why their therapeutic levels, why their excretion may be a little slower than a patient who is normal without any issues with the kidneys. Now, the pharmacodynamics of the epoetin alpha has the same effects on the body as the endogenous erythropoietin. It stimulates production of the red blood cells, and kind of repeating myself there, but the rate of the hemoglobin increase varies among patients and is dose dependent. However, the dosage over 300 units per kilogram 3 times weekly, or 60,000 units once weekly, are unlikely to produce any additional biologic responses. Now, contraindications and precautions. The use of epoetin alpha should be avoided in uncontrolled hypertension and in cases of hypersensitivity to mammalian cell-derived products or human albumin, because anaphylaxis can occur. Now, the adverse effects occurring during the epoetin alpha therapy appear to reflect the patient's underlying disease process or their post-operative state. Now, they can have fever, headache, cough, rash, nausea, diarrhea, vomiting, edema. These things have been noted as adverse effects in patients. Now, as far as any drug interactions that are known to occur with this one, there are no current drug interactions that are noted. Nursing management of the patient receiving the filgrastim. Filgrastim is licensed for use in both adults and children with cancer to increase their neutrophil count. And this drug is used for patients with cancer who receive chemo following bone marrow transplants to reduce the duration of the neutropenic or the neutropenia-related clinical sequela, and we call it febrile neutropenia. And what it is, a patient will have a fever, and this drug is administered as a single sub-Q daily injection. It can be given bolus by short IV infusion for up to 15 to 30 minutes, or by continuous sub-Q or IV infusion. The pharmacokinetics of this drug begins to work as soon as it combine with its receptor sites, and absorption and excretion occurred through the kidneys. The elimination half-life is about 3.5 hours. Now, the pharmacokinetics of this drug is produced by the Escherichia coli bacteria that have had the human GCSF gene inserted, and it regulates the production of the neutrophils within. This drug regulates, as I told you earlier, neutrophils within the bone marrow, and the recombinant DNA GCSF acts the way that the endogenous GCSF does. Now, this drug stimulates and mobilizes the cells that are progenitor cells for neutrophils into the peripheral circulation. Now, contraindications of this drug. The only contraindication to administration of this is hypersensitivity to E. coli derived proteins or any other product component. So you just have to pay close attention to see if the patient would have any kind of reaction due to it being an E. coli derivative. Now, adverse effects. Determining the adverse effects of this drug in a patient receiving chemo is difficult because all the effects recorded during clinical trials, the drugs can also have sequences of malignancy or cytotoxic chemotherapy. Drug interactions with filgrastim have not yet been fully evaluated, and drugs such as lithium carbonate or can potentiate the release of neutrophils and should be used with caution because of the synergistic effect that may result. Consequently, CBC levels should be taken more than twice per week during treatment. Assessment of relevant core patient variables. Health status. You need to determine whether the patient has non-myeloid cancer or has neutropenic fevers or severe chronic neutropenia, or has had a bone marrow transplant, or is a candidate for peripheral blood progenitor cell collection, because these states are indications for use of this drug. Now, we have the interleukin-11 or the Oclavecan facts to remember. This drug is used to prevent thrombocytopenia in cancer patients. It's a recombinant DNA polypeptide that stimulates the production of platelets in the same way of the endogenous interleukin-11 does. This drug is administered daily by sub-Q injection, and the major contraindication: do not use with or immediately following cytotoxic chemo. So if a patient's gotten chemo to kill any kind of cells, you would not want to give this drug immediately following. And the most common adverse effect: nausea and vomiting, fluid retention, and febrile neutropenia. And the most serious adverse effects are CHF, pulmonary edema from fluid retention, and atrial arrhythmias. Now, with this drug, you want to be very careful here because it can cause fluid retention. And any patient who would have any issues as far as CHF and all, you want to do it with caution, and you want to make sure that you're monitoring the intake and output of this patient. Now, lifespan alert: older adults may be more likely to develop atrial arrhythmias while taking this drug. And maximizing the therapeutic effect: do not shake or excessively agitate the valve. Begin administration 6 to 24 hours after the completion of chemotherapy, and continue until the postnatal platelet count is greater than 50,000 cells per millimeter. Discontinue 2 days prior to the next chemotherapy. Now, minimizing the adverse effects: monitor fluid intake and output, and maintain aseptic technique. You need to be very, very cautious with these patients when you're giving them these drugs, because a lot of them can be, as I said earlier, in a neutropenic state if they are bone marrow recipients or doing anything that's dealing with chemo. And you really need to be very careful with hand washing, etc. And the most important: patient education. Contact the prescriber if fluid retention occurs. Avoid activities that would increase the risk of bleeding. And the ongoing assessment for the Oclavecan, the interleukin-11. Monitor the patient's platelet count throughout the therapy of this drug. Continue therapy until the cells equal 50,000 cells per millimeter. Also monitor the other components of the CBC to detect any adverse effect. And until the platelet count is adequate, monitor the patient for bleeding. And therapy with this drug is effective if the platelet count rises to normal and if severe bleeding is prevented. Now, here we are with the chapter summary. Going back over, kind of giving you just like a brief review. The immune system is a complex system of cells and chemical mediators that prevents foreign pathogens or cells from invading the body. The mature blood cells differ in structure and function, but all develop from a common progenitor cell or stem cell within the bone marrow. Blood cell components may be altered because of the pathophysiology or drug therapy to treat a disease process. And drugs that stimulate the immune system to produce blood cells are hematopoietic growth factors. Drugs that stimulate production of the RBCs are erythropoietic. Those that produce white blood cells are colony stimulating factors. And those that increase platelets include special interleukin drugs. And these drugs perform the same function as their endogenous counterparts. Chapter summary continued. The recombinant human erythropoietin, also known as epitin alpha, is used to treat anemias that result from decreased production of RBCs, and which we know is erythropoiesis. Tissue oxygenation cannot occur optimally with anemia, and anemia is common in chronic kidney disease, CHF, and other types of drug therapy that can be administered to a patient. And iron is needed to form the red blood cells, or RBCs. Epoetin alpha therapy that is not effective or has a diminished effect is likely attributable to iron deficiency, which may also be absolute or functional. Most patients who receive epoetin alpha therapy need iron supplementation at some time from or for the RBCs to be produced. Chapter summary continued. The colony stimulating factors are the granulocyte colony stimulating factors and the granulocyte macrophage colony stimulating factors, the GM-CSF. They stimulate white blood cell production, and neutropenia and other suppression of the white WBC count frequently occur after chemotherapy and the use of other types of drugs. Low WBC counts, especially low neutrophil counts, place the patient at an increased risk for contracting an infection. And unlike other interleukins, interleukin 11, oprelvicin, has hematopoietic properties and stimulates the production of platelets. Without an adequate number of platelets, proper blood clotting cannot take place. The patient is at risk for excessive bleeding. Internal or external bleeding can occur. And last but not least, the drugs promote production of blood cells should not be given at the same time as chemotherapy because of the rapid producing cells are likely to be killed due to the drug therapy of the chemo. And here at the end, I did kind of do the chapter review questions. And the first question, what are the principal polypeptides or glycoproteins involved in hematopoiesis? And we know it's erythropoietin and thrombopoietin. Question 2, why are people with chronic kidney disease anemic, and anemia that results from inadequate levels of stimulating hormone erythropoietin is the cause of anemia in patients with kidney disease. And the next one, what is the major risk to people who are neutropenic after chemo? And patients are at higher risk after infection due to suppression of the immune system, and the neutrophils are destroyed. So that's why they have they're neutropenic after chemo. Remember, chemo kills cells. It kills good cells, and it can also kill bad cells as well. It's designed to kill bad cells, but it can also kill good cells that are essential to keeping the body in homeostasis. And the lack of being able to fight off an infection would show the body is not in homeostasis. And it says, next question, how are platelets produced? Platelet production, although stimulated by cytokines, is mostly dependent on the action of the interleukin 6 or the peptide called thrombopoietin. And as we said earlier, this thrombopoietin is produced in the liver, and it's low platelet count. A low platelet count stimulates the production of this polypeptide, and platelets are important because they have a factor in normal blood clotting. The next one, why do patients with CHF require close monitoring of their intake and output of fluids when they are started on the oprevlican? The answer to this one is you have to assess for CHF, pleural or pericardial effusion. They're susceptible to developing CHF because of fluid retention due to taking this drug. And you have to also assess for a history of atrial fib or flutter or other cardiac disorders or cardiac medications, because these factors may increase the risk for atrial arrhythmias during this drug therapy. And the last question, your patient has CHF and chronic kidney disease and is receiving epoetin alpha. Why should the target range for hemoglobin be set lower than what is usually considered normal? And it says because these patients are at risk, because the rising the levels too quickly can cause issues. It can also cause them to have seizures, and it can also cause cardiac events if these levels are raised too high in patients with renal failure. They are put at greater risk for death or serious cardiovascular events if the hemoglobin level is raised too high. And the goal for them, it should be between 10 and 12 only. It shouldn't go any higher. So they have to monitor the hemoglobin, because too many if they produce too many cells in production, it causes the body to react, and it can be detrimental to them due to their chronic disease process. That's it. That's all I have. Here's my references. It is our book, Drug Therapy and Nursing, the 4th edition, and all my information was received from this book. And that's the end of my presentation.